Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director for Clinical Education and Partnerships at SICA, where we partner with healthcare providers to offer body composition solutions. I'm excited to be joined today by Dr. Michael Glickman, who is triple board certified in family medicine, lifestyle medicine, and obesity medicine. And he founded Revolution Medicine in 2021. And I'm going to have you tell us all about that. So thanks for joining us.
Sure. Thanks so much for joining me. Or thanks so much for the invitation. I'm thrilled to be here, and like you mentioned, I started Revolution Medicine just about 5 years ago. Initially with a background in primary care, but decided to subspecialize in obesity medicine. We're a big comprehensive obesity center in Washington, D.C. We have a team of about 22 providers now, a mix of MD, PA, nurse practitioner, and nutrition and fitness coaches. And we've expanded to now cover 4 different physical locations from Virginia up to New York City, and we serve patients in 8 states across that network.
Wow, you guys are growing fast. And I think, you and I, of course, have connected at some of the conferences where we go for our professional education. But I've also been excited that you guys have really done an incredible job integrating Sika and body composition into your practice. And so I'd love for you to tell us a little bit more about that because that's grown along with you.
Yeah, absolutely. So I think this is a very interesting topic, and one that I even mentioned at the A4M conference a few days ago. But we just got our first body composition machine a year and a half ago. It feels like we've been doing this forever, but when I looked back at my notes, we made installed our first machine in the middle of 2024.
Okay.
And so knowing how important body composition is today in obesity care, um, and how quickly and how fast this science is moving, and knowing today how crucial it is that we have that data, I think it's so interesting that our practice and so many other practices out there were doing obesity management without body composition data. When we were doing this in 2021, 2022, we thought we were providing, excellent high quality care. And this was before people were talking about body composition data. This is before we had, a lot of like the step one and surmount one trial data where we didn't necessarily know, what percentage of patients losing weight was fat mass versus fat-free mass, and what are the implications of that. I think obesity management 1.0 is really just, hey, let's help patients lose weight, and let's help them, de-escalate their chronic diseases and just live a healthier life. But now we've really so quickly moved into obesity 2.0, which is more personalized care, understanding body composition, helping patients lose weight thoughtfully and safely. And now I think body composition is so ingrained in our protocols and so many other practices that are expanding. And I think it's absolutely where the field needs to be today.
Oh, I love that. I love that 2.0. Definitely. And even, I think you and I were talking a little bit about the A4M meeting that you were just at, and how obesity care intersects with longevity medicine. And so that may even be our 3.0 there. But, I know you were able to give a talk about sort of body composition and how you've been able to integrate that into your programs and even the return on investment piece, because we know that that's a part of it. I know from all the conversations I have with clinicians, they're wanting to figure out how they're going to, get their return on something like the purchase of their BIA device. So yeah, tell me a little bit about how that talk went. I'm sorry I couldn't be there to hear it in person.
Yeah, it was so much fun. This was my first time attending a longevity conference. I was very excited to explore that space more, just being more in the traditional obesity and lifestyle medicine space. So it was fantastic. And like you mentioned, this obesity 3.0, I see these fields of science intersecting. It's not. I don't think it's a matter of if. I think it's a matter of when. And I think the start of obesity 3.0 is where we're not just looking at weight loss. We're not just looking at metabolic, cardiometabolic markers over time. We're not just looking at even body composition markers, but we're also looking at functional data. I think that's the next natural evolution of this. And I think we've even talked about this before at some of conferences we've attended together, but I think being able to obtain and integrate things like strength assessments, aerobic uh, fitness capacity, quality of muscle, that being able to fuse that data together with the actual composition of body mass and skeletal muscle, I think it's going to be so important because it's not just going to be about how much weight are we losing, how much muscle or fat are we losing, but what's the quality of that muscle, what's our fitness, what's our strength, and I think that's going to help us help patients lose weight even more safely and more thoughtfully, making sure we're setting really thoughtful goals for patients on what's their protein requirements, what's their fitness requirements, and their strength requirements. So I think that was something I had in the back of my mind going into this conference, and there was a lot of vendors there that I think are already leading the way in these conversations. Vendors that are offering these functional strength assessment tools,
Mm.
and also things like cardiometabolic fitness tools like VO2 Max. I think that's another exciting field in the longevity space that a lot of patients are starting to ask about.
Yeah, that's interesting. I know the vendors and the exhibits at that meeting are expansive. So it sounds like you were able to take some time and visit lots of different new and upcoming things in the space. Anything stand out as something exciting that we should be on the lookout for?
Yeah, I think for me, it's falling back to that functional data. I think our practice, we're definitely going to be investing in some of that technology in the years to come, so we could find ways to fuse some of that functional data for our patients. But there's so much happening in the longevity space, and I think that intersection is going to be happening sooner rather than later. Patients are asking for it. Longevity medicine is such a viral topic right now,
Yeah.
and I think to me, really, longevity medicine is just kind of a repackaging of primary care. I think primary care, um, I think in today's healthcare ecosystem has just become about disease management, but not necessarily treating the upstream root causes of a lot of those diseases, because some of our best primary care clinicians just don't necessarily have the time to have those conversations about nutrition and exercise programming and lifestyle topics, because healthcare providers are so busy today. So I think longevity medicine is really just positioning itself as that upstream primary care, and so the question is, what medications in the longevity space are evidence based? How can we fuse that together with obesity and lifestyle medicine and primary care just to help our patients live their best lives? So we need so much more data on a lot of these new medications, peptides that are being used, and I think as more data comes out, we'll do our best in the academic community to try to decide, what works, what doesn't, and what's actually going to help our patients be healthier.
Well said. Yeah. And it's funny, even just thinking about that word of longevity. I know we talked about this, how the GLP-1s can really even, be considered longevity tools, because really, if that's extending the years of good quality lifespan, as they say, that's what they're doing, right? Like I can't even keep up with all the news and the media on what new indication there is, or what, brain health and all these other things that the medication classes that we're seeing are being able to impact, right?
Yeah, for sure. I think nobody in our academic space is going to be surprised if there's a headline one day that says that patients who use GLP-1s live longer. I think the data is very clear that most outcomes improve for patients with overweight or obesity who are taking GLP-1s. And we know that patients are seeing reversals of diabetes, prediabetes, improvements in blood pressure, cholesterol, fatty liver, kidney disease, reductions in heart attack and stroke, and some of the more recent semaglutide trials. So I think it's only a matter of time before we see that more longitudinal data after we see patients taking these medicines for years, even decades. And, how do we quantify uh, the years of life that we're adding to these this patient population. So the question is, can we see this data get extended to all patients? For example, in some of the semaglutide trials, they were looking at heart attack risk reduction in a very high risk cohort of individuals, and they found about a 20% reduction in heart attack or stroke. But those were patients that are already had some established heart disease. So when will we get that data that more users of GLP-1s could potentially see years added to their life? So I think folks in the longevity space are already trying to, lead the way with that. And I think time will tell where the science takes us and where the data takes us.
Yeah, and I think I've been so focused, or we've all been really so focused on access and affordability too. And I was just saying this over the weekend that the amount of change, even in that area, over even the past year, where the model for how much they cost and how to get these medications has changed so many times. I mean, that's gone faster than anything I've seen in the past 20 years of being in this space. So it is exciting to think that we're sort of moving quickly, and hopefully getting the medications to the people that need them most. And I know that is some of the concern that you see talked about a lot, is, are the right people taking, the right people, right, the people who need the medication taking it, getting it, and then are people who don't need it taking it, and how to sort of regulate that or conceptualize that so that it's more, less harm and more benefit. I think that's something we grapple with a little bit here too.
I agree. We have so much, still so much room to grow on that topic. I think like you said, we're thrilled that the costs have come down across the board. We're thrilled that just even in this year, significant reductions in both of the major GLP-1s that are used today. So compared to just a few years ago, where the listing price was easily over $1,000 just per month. So I think we still have a long way to go in terms of the conversations about equity and, like you said, can patients that really need these medications get them? I think if we do get to that point one day where the playing field for cost is leveled out and everybody who needs the medication can access it, I think that will be an exciting time, if or when we get there. But definitely a step in the right direction.
Absolutely. So what else at the conference was interesting or, upcoming? I know the education sessions, there's so many there as well. And I always have FOMO when I don't get to go to the conference and hear that myself. So then I'll invite you to tell me
Yeah.
what was good. What did I miss?
Yeah, I mean, I could speak to the session that I gave. So I gave a talk on the intersection of body composition testing and obesity care, and I was just thrilled to see that so many of the providers that were at that session are already using body composition technology in their practices. It was almost a full room, and I pulled the room and I said, how many of you are currently prescribing anti-obesity medications, GLP-1s? Lots of hand raised, and then I asked the room, how many of you are already using body composition in their practice as part of these protocols? And most of the folks kept their hand up that they're already offering this. So I'm
Wow.
thrilled to see that body composition has so quickly established itself as really a critical piece of obesity care. And I think as practices continue to expand that technology into their own practice, I think it's going to be better for the system and better for the patients that are coming in, because nowadays you can get GLP-1s everywhere. You could fill out a form on a website and maybe without even talking to a human, have it show up at your doorstep the next day. It's a whole other topic of conversation we could probably
It
spend
is.
spend hours on. Is that good? Is that bad? But that's the reality of where we are today. So for practices that can build a comprehensive weight management program and fuse in things like nutrition coaching, fitness coaching, behavioral health, and body composition, I think are really going to lead the way in high quality care. And I think patients want that. I think when patients see a provider that's offering that comprehensive care and being able to follow those body composition changes over time, I think it leads itself to a better relationship with the provider. I think it leads to the patient sticking with that program and that practice longer. And I think it would lead to better outcomes too. So I was really excited to see a lot of providers really doing that.
That's great. And then also, I know you talked a little bit about the reimbursement component and, making it financially feasible. Did you have, conversations with others about what they're doing? What's happening
Yeah,
in
yeah.
their
I met providers that are doing a mix of insurance and cash pay programs. And our practice is insurance based. So we do bill insurance for those body composition appointments. And I talked in the session about how insurance reimbursement is still moving in the direction of adding that 0358T procedure code. So Medicare is covering it. We're seeing in the DC area some commercial plans are covering it. But I think the trend is going in the right direction, that commercial plans and insurance plans in general are seeing the value now of getting that body composition data, and it's helping us treat our patients more safely. So I mentioned that in the session that the coverage is getting better, but even if we don't have that coverage of the procedure code itself, you could still bill insurance for the time that you're spending with your patient in that appointment. So in our practice, we carve out about 15 to 20 minutes for the body composition visit. The scan itself only takes a minute or two. It's so quick to do these body composition scans. I think the slowest part of that visit is actually patients just taking their shoes off.
Yes,
But
totally.
once we get them on the machine, it just takes a minute to get the data, and then we spend about 15 minutes of with the patient, and we pull up their report on the screen. We walk through all of the metrics together. So just explain to them what the data is showing, what their trends are, and help them really understand that body composition over time. So that is just a metabolic appointment is going to be universally covered by insurance, because we're talking about that body composition data in the context of their chronic condition. So whether it be obesity, hyperlipidemia, high blood pressure. And so we don't have any issues with billing insurance for that an E&M office visit for that face-to-face time. And then sometimes you could even build that procedure code on top of it. So we had a lot of, I think, hallway conversations with providers at the conference about some of those strategies, and some folks found it pretty exciting.
Yeah, that's great to hear. Are they overwhelmingly non-insurance based in that space, or is it a mix? What kind of?
I would say a mix. Yeah. And we talked in the session about how you could layer in body composition testing as a package part of your program. So if you have say a weight management protocol and a cash-based practice, adding that body composition data could really increase the value to those patients. So help separate yourself from an online program, for example, that's just going to be more about getting the medication to you, maybe some light lifestyle coaching, but having that body comp data as part of that cash-based program can really drive retention, drive patients to stick with you, drive direct or even indirect referrals.
That's great. I think something you said that's really hitting with me is just getting that body composition assessment and the counseling as part of comprehensive care is really, where we know that's going to last, right? So if you've been taking care of patients living with obesity for a long time, we know that, one medication, one visit is not, it's not going to do it. It is almost the longevity of the relationship with the patient. And you're going to try different things, and new meds will come out, and some will do better with some or others. You have non-responders, patients who aren't seeing those same results but may stay on them even for these other health benefits outside of their weight. So I think all of that, those are kind of the things that I'm excited about, is a new opportunity for more people going in to, get help with, either getting well, staying well, whatever, but then getting that added benefit of the nutrition, behavior, exercise, and all of those other components of that, that lifestyle, that bigger picture, getting those folks together on their team and then keeping them there, right? Knowing that this is a long-term relationship.
Right, exactly. And that's what we tell patients that join our practice. One of the most common questions patients come in when they see us is, hey, how long am I going to be taking this medication? How long do I need to be on it? How long am I going to be seeing you? And we really try to reframe that question and that conversation, because if you say, someone, you've had a heart attack, God forbid, and you get referred to a cardiologist, you're probably not going to ask that cardiologist, like, hey, how long do I need to be here? Heart disease, just like obesity, is a disease, and you very likely are going to keep seeing that cardiologist for a long time. And maybe it's just once a year as your condition improves. But with obesity, we try to educate that it is a chronic disease, and just seeing someone for 3 months or 6 months is not necessarily going to change or make that disease state of obesity go away. So I think reframing that conversation for continuity care goes a long way. And with that, we tend to see pretty high rates of engagement and retention in our practice for the long term. So not just about, hey, I'm going to reach a goal weight and then I'm going to leave the practice, like some of those older, 1.0
Yeah.
models were just about prescribing medicine and then reach a goal and then cycle back, but more about helping patients maintain their weight once they've successfully lost it.
Yeah, and I think, I talk about this a lot in sort of the behavioral context of when weight loss is your only goal or outcome that you're looking for, once you hit that place where you're, hoping to get to, and you're in more of a maintenance phase, it's hard to stay excited, like motivationally, about staying at a same number, right? So that's where I think all of the other components to goal setting and in motivation come in. And that really is where I see body composition as a really, is a sweet spot, right? Like athletes can work continually on functional health and improvement, cardiovascular improvement, all of the fitness, parameters there. They're always setting goals and reaching them and setting new goals, right? So with weight loss being the goal, it just ends right there, right? Because staying at the same weight is hard, but being excited by that number is not as exciting. So I think that's a
Right.
really important piece of this too, is saying, now, like, we've evolved. There's all sorts of technology available. There's all sorts of ways that we can assess our health. Putting all of these things together also helps people focus not just on one thing, right? I mean, it's easy to become obsessed. I mean, so many people get very focused, hyper focused on the weight and the number. But when that's the only thing you're measuring, right? Like, that makes sense. So when you have an array of things that you're looking at, you're putting it in context of the person's values and their life at home and their quality of life and engagement and, all of those other components. I think that's really another big service that we can do to helping people stay engaged with their teams long term.
Yeah, I think you're completely right. Once someone does reach their goal weight, a lot of times the question is from the patient, okay, what next? I've met my goal weight, my blood pressure is better, my A1C is better, my cholesterol is better. So, now what? And I think in this space, there's never a finish line. I tell this to patients all the time. We don't reach a finish line with our health. It's constantly something that we're always trying to optimize and always trying to do our best. So I think this is where that body composition data can be extremely helpful again, because we can really help patients understand, what is another goal that we could set. And this was even a case study that I presented at the conference where we pulled a report from our Sika table space, and this was I think maybe a 56-year-old male who had done excellent on tirzepatide, and there was a 6-month gap between his two Sika readings where his weight was totally flat, and he got a little discouraged. And the question is, okay, why am I not losing more weight? Am I at a plateau? Do I need to change my medications? And we actually found below just the weight itself, a 5-pound increase in the skeletal muscle mass with a simultaneous 5-pound reduction in fat and some visceral adipose as well. So it was really interesting to show him that even though the weight itself was stable, he was really still making a lot of strides in that more favorable body composition ratio. So it was more of an appointment to celebrate at the end than to be discouraged about. And so I think those are always exciting when we can give patients those reports. And another reason I'm excited to fuse more of this functional data into our practice, that obesity 3.0, I think that's the direction we're going, where we could actually, help patients set that next goal of maybe we've reached our goal weight, but hey, like let's set a goal to increase our strength by
Mhm.
this amount, over the next 3 to 6 months. Are we going to target core strength? Are we going to target our lower body, upper body? I think being able to put those protocols into place is really going to make a big difference.
Yeah, I do. I really am very happy that we're moving away from just those numbers that can be so, I mean, they're very damaging long term to just be so focused on that one thing. So, I think we do a lot in the behavioral space of getting people to accept where they're at and be able to move past some of those old frames of reference. But it's really nice to see that happening, in programs like yours, where you're offering that all sort of together in one package. So,
Yeah, absolutely.
well, yeah. So it sounds like exciting conference, lots of good, connections and ideas and new things out there. Um, how do you, as a provider in this space, how do you evaluate what's from new stuff, right? Like there's not a whole lot of evidence yet, but it might have some future potential. How do you evaluate what's going to be a evidence-based treatment or not? Because I'll tell you, even from someone who's been doing this a long time, I get confused. Some of the stuff that looks really good and entertaining and exciting, I don't know if that's going to be an evidence-based treatment or not. Any thoughts there on how to evaluate that stuff moving forward?
Yeah, that's a great question. And I don't know if I have the best answer. I mean, there's so many therapies out there that are being looked at, peptides, hormones. There's so many things that it can feel a little bit overwhelming. And, where do we find this intersection of evidence-based care where obesity and lifestyle medicine meets longevity? I think we'll get to that point, but we need human trial data. I think whenever I see a medication with just mice studies as being kind of the most important data point out there, leaves a little bit to my imagination. We need to see human data. We need to see human trials that are conducted across a broad range of individuals. I think we also need meta analyses of multiple studies being able to get that compounded data. And I think that's what we have in the obesity space, because we're not just looking at one trial for one medication that had a really low end value. We're looking at hundreds, thousands of patients across multi-center studies and random, of course, double-blind randomized trials. I think that's another thing that could be lacking in that space is they're not necessarily randomized placebo-controlled trials, and we really need that just for sound decision making.
I also think, putting my patient-centered hat on a little bit too, is there is room for maybe if it's safe, right? I think the safety piece has got to be there. But if it's something that's safe and maybe just doesn't have a lot of evidence yet, like there could be space for trying some of the therapies and seeing how your outcomes are, right?
Yeah, yeah, I wouldn't disagree with that at all. I mean, you could almost make an analogy to like a multivitamin. Like if a patient comes into my practice, I'll put my primary care hat back on for a minute. If someone says, "Hey, I found this new multivitamin online, I want to give it a try," um, pretty safe to say I think that's fine. I don't think you're going to have a negative outcome by starting a multivitamin. You could talk about, hey, do we really think you need that? Are you eating a balanced diet? Are you getting all of your your vitamins and minerals just through the foods that you're eating every day? But so maybe we don't need to be on an expensive vitamin regimen. But I could also say you're going to be fine either way. You're not going to have a major um, side effect incident from that vitamin. So could you make the same argument with certain tools in the longevity space? Maybe, if that safety data is there, that we're not causing harm. I think we always have to follow that Hippocratic oath of first do no harm. So if we could answer that question, I think we could build potentially protocols on top of that, where we could look for what are the potential beneficial outcomes.
Yeah, and it also reminds me, patient centered, but also not a one size fits all, right? So if you're going to someone who's like, I have all my patients on the same thing, regardless of who you are and all of that, I think that's another piece where, there's very few things that are going to apply to everybody. And so being able to pick and
Right.
choose what works for the person and making sure that you're ending up in a balanced place, not taking so many supplements that you don't focus on the nutrition part of the equation and then not being so obsessed with the nutrition equation that you're missing on the joy and engagement in your life side of things, right? Like there's a lot of balance that I think is important. And sometimes I think anything we get too obsessed with um, can have a dark side too.
Yeah, I agree. I think that personalization is so important, and that's something that has already emerged in the obesity space. I think we're we're so early in this journey of what medications are available to us to treat obesity. We have two major GLP-1s, we have a few oral medications that have been on the market for a long time in terms of just simplifying it to what are the most effective options out there, at least 10% body weight loss. Um, we we try to be very personalized in our practice, and we don't say, hey, every person that walks in the door, here's this medication, this is the protocol that you have to follow. We really try to get to know patients, talk about their medical history, the symptoms they experience, what's their level of food noise. You can get into conversations about obesity phenotype based on the types of symptoms that they've experienced in their life, and potentially offer them a different treatment based on that background. And I think as more and more obesity medications come to market, there's over 100 medications in the R&D pipeline. It's going to become very personalized, very precision. Why are we making this choice for you as an individual, and why is the patient that we're seeing after you maybe going to get a different recommendation? So I think that's so important in the longevity space too, that we do want to have protocols, but at the same time, they should not be black and white protocols that every patient should go on the exact same stack and be at the same dose. It should really be customized based on the individual and what their health needs are.
Well, that wraps it up beautifully for me. So I'm really glad that you were able to come on and talk with me today about this. Any lasting thoughts, or where can we find you and connect with you if we're interested?
Yeah, absolutely. Well, I'm excited to stay engaged in the longevity space, I think I'll add the A4M conference into my annual conference visits. I think it's important to stay ahead of that curve and see what's emerging because patients are asking us these questions. We can't ignore that, and so we have to figure out what's real and what's not real. So I'm excited to continue to stay engaged. And if any patients are looking for comprehensive obesity care, of course they could always check out our website revolutionmed.com. We see patients like I mentioned before, from Virginia all the way up through the New York metropolitan area.
Wonderful. Awesome. Well, Michael, thanks so much. And I know I'll be seeing you probably in a couple months at our next conference.
Sounds good.
All right. Thank
Appreciate
you.
it. Thanks so much.